Welcome to Medicine Handy Point. Today we will discuss a topic in which we will discuss history taking in a patient presenting with ankle edema. So let's start. So once a patient comes with ankle edema, we'll ask about the onset and duration. Like we will ask whether the ankle edema developed suddenly or it was gradually happening. Then we'll ask about the duration, and important thing is that it will help us guide to some diseases. If the ankle edema development is acute within 72 hours, then it could be DVT, especially if it is unilateral. So that's why we have to ask about the onset and duration. Then we'll ask about that the ankle edema, is it progressing, or it is just intermittent phenomena, or it is regressing. So we will ask about the progression. Then we'll ask about the asymmetry and symmetry. This is very important slide which you can see down there. Here you can see the different causes for bilateral symmetrical edema, which you can see, and then you can see unilateral asymmetrical edema. As you can see that always bilateral edema, ankle edema, will be some kind of a systemic illnesses like congestive cardiac failure, cor pulmonale, CLD, nephrotic syndrome, malabsorption, malnutrition, immobility will lead to bilateral pitting edema, dependent edema, hypothyroidism leads to non-pitting ankle edema, and drugs like calcium channel blocker also causes non-pitting bilateral edema. Now, unilateral asymmetrical edema is usually due to DVT local causes like DVT, cellulitis, trauma, arthritis, low limb venous obstruction by some kind of a tumor in the abdomen or in the groin region, and lymph edema. So these causes basically unilateral edema. Now, then we will ask about the extent of the edema. We'll ask whether the edema is just confined to the abdomen, it has progressed up to the thigh or abdomen. Then we'll ask about the aggravating factor, which things aggravate the ankle edema, like dependent edema, which get worsened by the end of the day, or some drugs like if the patient is taking calcium channel blocker, we can attribute the pedal edema to those drugs. Then we'll ask about the relieving factors like leg elevation, especially in the if the patient is having venous drainage deficiency, like some kind of varicose veins or extrinsic venous compression. These edemas usually get better with leg elevation. We'll ask about any drugs helping to resolve the ankle edema like diuretic. Then we will ask about a certain symptom like any oozing from the leg, or any skin discoloration like chronic venous insufficiency leads to skin discoloration, while oozing of the leg can occur sometime in the congestive cardiac failure, cirrhotic, and nephrotic patient. They have some oozing of the fluid from the legs. Then we'll touch upon the etiology. So I have a systemic approach to that. For this, I will start from the skin condition and go deeper and up. So focus now. So we'll start with skin condition. Cellulitis can cause unilateral edema. Then after skin are the bones and muscles. So rheumatological condition like rheumatoid arthritis, SLE, scleroderma. In the context of pulmonary hypertension, scleroderma actually leads to pulmonary hypertension. It can cause ankle edema, while SLE can involve the kidneys, leads to nephrotic syndrome like picture and can lead to pulmonary edema, and rheumatoid arthritis can cause local inflammation and leads to edema. So we will start with the skin, then rheumatological condition, then is followed by there are vessels in the deeper down, so DVT can cause. Then there are veins which can be compressed by the mass in the abdominal pelvis, so extrinsic venous compression. Then there are kidneys. Kidney failure can lead to bilateral edema. Nephrotic syndrome can lead to bilateral edema. Gut problem like malabsorption, liver problem like CLD, heart problem, congestive cardiac failure, uh, lung problem leading to corpus pulmonale, and in the end hypothyroidism. We will touch upon that. Some drugs which can lead to ankle edema, these include calcium channel blockers, steroids, zolidine, which are anti-diabetic drugs, and said these all leads to fluid retention. They will ask about OCP use, as OCP can cause DVTs. So we will ask about OCP. We'll ask about nephrotoxic drugs as well if the patient is taking nephrotoxic drugs. So we'll ask about that. Family history will be important in the context of cardiac condition and thrombophilias, because the patient may be prone to DVT. So in a family history, we should focus on cardiac condition and thrombophilia. This was all about history taking from a patient with ankle edema. I hope you liked the video and please subscribe to the channel.